Hi, my name is Jody Krestek, and today we're going to be talking about pediatric advanced care planning. Hope for the best and plan for the rest. Thank you for joining me. Our objectives today are to define pediatric advanced care planning and differentiate from advanced directives, to describe strategies for approaching the conversation with patients, parents, families, and familiarize yourself with existing resources for pediatric advanced care planning. Advanced care planning is a process. It's not one event, and it's planning for future care based on a person's values, beliefs, preferences, and specific medical issues. The process can happen between a family and the healthcare team and may include a child or young adult, depending on their developmental ability. We use the term advanced care planning as an umbrella term for many things. Hopefully, many of you have watched the recording didactic on advanced care planning, resources that Helene would, our world expert. There's so much out there in this realm. For me, it's been helpful to think about these resources and documents in buckets. ACP conversations are just that, the conversation patients have with the family and their clinicians about their future health care based on the family's values, beliefs, preferences, history, culture, and specific medical issues. The frequency and quality of these conversations are highly variable, which has led to development of many tools. So the ACP tools for Peds are resources, they're toolkits, they're workbooks, they're websites, they're guides to improve the quality of conversations. And there's many of them. For example, voicing my choices for adolescents and young adults, and there's English and Spanish versions of that. Conversations that Matter from the National Institute of Nursing Research. There's My Wishes for younger kids. And then sometimes games can be helpful, such as Go Wish or Hear My Voice. They just help with the conversation. We will be talking about two of the advanced care planning, Neurojourney and Serious Illness Conversation Guide from the pediatric version from Canuck Place. The advanced directive is another umbrella term for defining and expressing the family's priorities for a child's life and values, including quality of life as defined by the family. For some family, if they get a smile once a day, that's good quality of life. And when at all possible, we involve the youth or the young adult in medical decision making. Individuals under 18 generally do not have legal rights to make an advance directive unless they're an emancipated minor, but most commonly they're involved as much as possible as they choose or have the intellectual ability to express their wishes. And finally, the POST or MOLST or POST, depending on where you are. This is a medical order written by a prescriber, like a prescription, for specific interventions at end of life. So the emergency medical technicians cannot honor an advance directive, and their default would be full treatment without a POST. I think of a POST as one outcome of the ACP conversation between the team and the family. In some states, the POST doesn't need to be signed by the family in pediatrics, but rather just by the physician and by a palliative care team member willing to verify that the conversation has taken place. So advanced care planning is a process. So you'll hear this a few times, but it's a process of reflection and communication to identify the values, wishes, and beliefs of the patient's future healthcare plans. In pediatric, of course, this includes considering the child's ability to understand, as we mentioned, and participate in specific decisions. And this definition comes from Canuck Place, which is a children's hospice and leader in pediatric palliative care. Another way of looking at it is it's that pediatric advanced care planning is ongoing conversation that enables the goals and wishes and treatment plans for the young person with a life-limiting, life-threatening condition. So these are conditions including medically fragile or medically complex kids. So for pediatric palliative care, we continue across a continuum in the community or in the hospital. It's not just in the hospital. Many of our patients, probably majority, are seen in ambulatory clinic or home care. NeuroJourney is the one that I had mentioned earlier. It's an advanced care planning document developed in collaboration with a neurologist and parents. It's particularly focused at children with neurological issues. And probably a third to maybe even more of the kids that we see in pediatric palliative care are actually have neurological issues. And so this was actually developed by a very famous neurologist, Julie Hauer, and others, as well as with parents. And that's what's really important about this is that the parents had an input. How do we have these conversations? And we have them early on so that a variety of concerns are brought up early in the journey. And so pediatric palliative care starts at diagnosis of life-threatening conditions. So some of these kids are in palliative care for years, and then they graduate when they're 21. Maybe they come to us when they're born, and they graduate and go to adult palliative care when they're 21. So it's a ongoing, continual process. And this is what NeuroJourney does so well because you have these conversations not only at a time of crisis when people just can't think straight, but it's ongoing, and that trust is so important. Some people may think if it's brought up sort of in suddenly, isn't this just planning for my child's death? They may worry, is there something they're not telling me? Why are we talking about this? So it's really important to respond to emotion first. When so what do you what tell me about the fear. Tell me more. So we want to respond to the emotion before we jump into perhaps a more difficult conversation. Maybe something like, it must be so hard to even consider thinking about that. And research shows us when envisioning the future of their seriously ill children, parents tend to stay close to the future initially with a focus on disease-related themes. But ongoing conversations uncover the deeper value-based elaboration towards the future. So to help parents start to look at that, and that's why it's an ongoing conversation. There's many benefits of advanced care planning. Certainly identifying and honoring the family's wishes. So we often talk about it. You really care for your child a lot, and we want to, as much as possible, honor those wishes. And if you can tell us what they are, if we can discuss what they are, it's going to help us make sure we, as much as possible, can follow what you would like us to do. So that is in encouraging the choice and control. We can't control everything, we know that, but as much as possible. In research, they found that families feel positive about their caregiving. It's like, okay, I've done everything I can to prepare for the future for my child who has a very serious life-threatening condition. Other families feel relieved, like, oh, it's a load off my mind. And now I can be at peace because one family said, I was having these 2 o'clock in the morning fears about what happens. What if he does die? What are we going to do? And to have it laid out and planned out can really bring peace of mind. It, of course, depends on the culture. Some cultures, it is not appropriate to talk about that. And so in advanced care planning, as I'd mentioned before, we need to be very aware of each situation because one size does not fit all, right? Circumstances change. It may be that the family's going through a really difficult time and they just can't have one more difficult conversation. Their past experiences, they may have had a trouble with their mom dying in hospice and oh my goodness, we did advanced care planning for her and she died the next day. Is that what you're telling me? No, we just have to really understand and build that trust with family personalities. Some people like to have all the things sorted out, and others are just tell me day by day. And as I mentioned, cultures, some cultures to talk about death is to invite it in. And there's many different ways to approach this, but again, individualize each conversation is so important to know the family communication. But what's really important is building that trust in the healthcare team. It doesn't mean that you have to have a long relationship. Sometimes, obviously, that's helpful, but trust can be built up quickly when we listen to the family and they feel heard and we speak from our heart. I'd like to have you listen to a mother talk about advanced care planning.
And I've said this to Dr. Howard before, if she doesn't realize that first meeting with her is really helped me for the rest of Barry's journey, because in my mind, because of everything Barry had been through in the last, especially the 6 months, I figured that some big event was going to happen and it would take him. And so the first time we met, she said that that probably wouldn't be the case at all. And I remember looking at her and being shocked, and I, what do you mean? And she said that in her experience and with her medical background, that what they usually see is that they slowly start to shut down, their bodies start to stop doing what they're supposed to be doing, and that it comes on sort of slowly, and that it can take up to a month, but you see a decline, that it wouldn't necessarily be a sudden onset death. And, and that gave me a different perspective. The thing didn't help me not be as scared when I got the call that Barry was seizing. He had been seizing and he wasn't stopping, and I'd go running to Seven Hills. But it really helped me when the end of his journey did come. The first thing that happened was they called and they said that Barry's stomach is, or I used to call twice a day at the same time, and I would talk to whoever the nurse was that was caring for him. And they said that his stomach was really distended. And I said, well, what do you mean? And she goes, distended like he's 9 months pregnant. And I went, what? And I was trying to picture this in my mind, and I was saying, well, what do you think? And they said that Dr. Howard had written for him not to have his formula, and they were going to put him on Pedialyte and just give it to him slowly. And it sort of did get a little better. It would go down for a while, and then it'd get more distended. And so that was the first thing that sort of happened. I had sort of noticed a difference when I had visited him before that happened, a little change in him, but I really couldn't put my finger on it. And then we thought he might be sick. I'm trying to remember. So they did a chest x-ray and we did a blood to make sure he didn't have influenza.
Yep.
And then he started sleeping more. And so I remember one day I was there visiting him, this was going on, and this had been going on for a few days. And I remember Dr. Howard was there in the room. She had examined Barry, and we stepped out, and I looked at her, and it was like I had this aha moment, and I said to her, oh my God, this is what you were explaining to me. I said, you need to tell me, because I need to start preparing, not only myself, but I was really worried about the girls. She did say that, yes, that this is what she felt was happening. She wasn't, you said you weren't positive, but she felt that that was what was happening.
So I wanted to share that with you so you could hear that it was very much up and down, right? And so that advanced care planning that the doctor had done with her had prepared her. So it's really important, if at all possible, to be able to do that. And then you can say, well, I don't know if the family is ready. We need to make sure that we're ready too. It's easy to stumble about, and we've all done that in our professions, but who in the family do you talk to about advanced care planning? In some cultures, maybe the mother's there all the time, but she wouldn't be the person that the family would want you to talk to. So when we have the timing, take a gentle opening. So, see if the family's okay to talk, or whether like, oh no, it's just too much now. and graciously accept wherever they are. If possible, accept a request for delay. I know we can't always do that if it's a very emergent situation, but if they want to delay, maybe just say, "Can you tell me more about that? How do you see what's happening with your child just now?" And think about worst fears. Are the worst fears yours or theirs? Are you very worried about, oh, what if I get stuck? What do I need to do? So preparing ourselves to have these conversations and be well versed with what the family and culture is. I wanted to share with you the serious illness conversation guides of Peds. It's adapted from the adult one from Ariana Labs. This is only the front page, and I know there's a lot of information on it. It's really just to show you the front page, and we're going to go through the steps with that. There are tips and considerations on the second page, so it would really be worth for you to um, look up online and print this off for yourself. The link is in the slide, but you can also Google advanced serious illness conversation PEDS. They also have a wonderful workshop that is free. It's a 3-hour workshop that you can sign up for to learn about how to have these conversations better. It's a really, really helpful. So let's talk a little bit about each step of the serious illness conversation. First, you want to set up the conversation, really introduce the idea and talk about the benefits, about preparing for future decisions, and of course, ask permission when we enter this conversation. And then assess the illness understanding of the parents. How do you see Joey's doing? What would you see has happened in the last few months, few days? And then share the prognosis with I wish or I worry, some of those remap, similar to remap that we're all learning about. Um, and then allow silence, explore that emotion, right? And we're learning more and more in this PCTC that emotion, unless we address that, we just can't get beyond that. So to allow silence is so important. And then explore those key topics. What are your goals for your child? Well, I want them to live as long as possible. Absolutely. And we would all want that as well. But besides that, what are your goals? Well, I really would like to get him home. Okay, some of those goals we can work on. And finding out what are the worst fears and worries. And sometimes a child's death isn't the worst fear that they have. Sometimes the worst fear may be, what if he lingers on and on and on and I take him home? How am I going to cope? And then to encourage sources of strength. What have you done in the past that have really helped you when you've been in crisis? And there's other tips and balances that will come on the back of that sheet to look off trade-off balance, benefits and burdens of interventions, and whether you should involve the child depending on the developmental age or the siblings, again, depending on the family structure, culture, and age and developmental age of the siblings. And then we want to close the conversation so it doesn't end abruptly, but rather just summarize and make a recommendation. So I'm just wondering if I could make a recommendation, and if they say, sure, you could make a recommendation, and check in with parents to see what they've understood. We all know that miscommunication happens easily in regular lives, and when we have serious conversation, it can happen more often at times. Then we want to document our conversation so our team members know exactly what the conversation was. If we don't, sometimes those questions come up again and again. We have a family that has been in and out of the hospital, and one of the reasons they don't want to come to the hospital is because people keep asking these same questions about resuscitation. So it's really important that conversations are well documented. And then to provide that document to the family so that they know what was discussed, because it's hard to remember everything. And when they have that document, they can, oh, that's right, we did talk about that. And then good communications with key clinicians. So having a goals of care talks at non-crisis times is really important, right? So families feel like they can't share unless they know that there's caring. So family members said, no sharing without caring. I can't share my heart with you, my goals, my wishes, unless I really know that you care. And it's important that every family know that. So in summary, a few pearls. So be aware of timing and cultural aspects when you go to have these serious conversations. Ask permission and accept refusal. And encourage the family to tell you more. Assess perspectives before sharing. So tell me more, or I worry. Open-ended phrases. Move at their pace. Sometimes families, you can tell they can only take so much. So don't push through your agenda, which is easy to do when in healthcare we've got things we want to get done, but we need to really move at the pace that the family can accept and respect and affirm their role. They are doing the best they possibly can with what they have. And expect that conversation will occur over time, especially for our Peds patients who are with us for many, many years sometimes, not always, but many times. So remember that with advanced care planning in Peds, it's an ongoing conversation. I wanted to leave you with some references so that you can look up some of those other articles that you may find more interesting, and certainly Canuck Place and the Neuro Journey. Thank you.